Good evening, everyone, and welcome to our Kawakib webinar series. Our topic today is basically pediatrics, ethics, and COVID-19. Our guest today is a physician known for her dedication to her patients in the pediatric population. In addition to being a dear friend, and she knows I'm not whitewashing. Actually, I never do that. She is also one of my first colleagues to venture us starting the bedside clinical ethics consult at AUBMC, and that was in the PICU. And it was a great moral support that you will never forget. And ever since, the service has been launched. So thanks a lot again, Marianne and Jad. So Dr. Amash Dalani is an associate professor in the Department of Pediatric and Adolescent Medicine at the American University of Beirut Medical Center. She is also the head of division of pediatric critical care, and I might add, doing an amazing job, really. Dr. Majdalani has been one of the pioneering physicians who felt bioethics plays a major role at the bedside. According to her, in order to have a comprehensive and complete evaluation and management of patients, it is necessary for us as physicians to integrate the medical, social, religious, financial, and ethical aspects involved in patient care in our daily bedside rounds. End of quote. And then she says, this will make us better physicians as well as improve the process and the outcome in patient care, end of quote. Dr. Majdalani teaches a unit on ethical issues in pediatrics as part of the Physicians, Patients, and Society 2 course given to Med3 students, as well as a pioneering module as part of PPS1 or Physician, Patients, and Society, actually 2, known as or called Spirituality in Medicine. Dr. Majdalani is an integral part of our program, as you can see, and you will continue to see as we move on. She is currently serving as the president of the Lebanese Pediatric Society, which gives us a lot of hope for the future. Thank you a lot, Marianne, for joining us, and the floor is yours.
Thank you so much, Talia, for this amazing introduction. And you know, أنا شهدت مجروحة فيكي with everything. Every time you throw something my way, I cannot but go with you because I know it will lead to improving our medical student and the services that we do. So thank you very much for being with us and always coming up with innovative ideas to improve and move forward in medicine in the correct way.
Thank you.
When Talia threw the idea of me presenting Kawakib, was it a couple of weeks ago, 3 weeks ago, my first reaction was no. And then, of course, being the person I am, and she threw a challenge at me, I could not say no for long. So I ended up saying, yeah, let's go ahead and do it. But what was the topic? And looking around with what's going on with the COVID, I thought I could share some concerns that we are facing with the pediatric population with the COVID and the lockdown. So I'm going to share with you some few slides. I promise you it's not a very long talk because I really would like to engage everybody in this discussion down the line. And then we'll take it from there. So let me share my screen. Okay. So can everybody see the screen just to make sure? I think so. Okay. So what is happening is that I think we're very lucky and very blessed in the pediatric population that children have not been affected by the illness as much as adults or in the same severity as adults. But I think what has been detrimental is that the children are vulnerable to the economic and social deprivation that the COVID-19 and the lockdown has done to them. So one of the first things that families have felt, and we have felt it in the clinics, and this is not talking only about AUBMC, but I'm talking about worldwide, is that the number of elective visits has dropped significantly. And I can give you statistics, we're at 1/3 of what we used to see. And this has led to immunization delays. So, of course, you know, vaccination is very important. We've eradicated diseases because kids meet the vaccination demands and so on and schedule. So this has definitely set us back. And the Ministry of Public Health actually issued some data last year at the end of the year saying that there was a 46% drop in immunization. Now, this is very alarming because so many diseases we have eradicated, and we just don't want, with this pandemic going on, to have some new disease, these old diseases resurface. So this is definitely one point of concern with the parents and us as physicians. So we had to find ways to be able to talk to the kids and see the kids. So, you know, telehealth has boomed. It goes very, very well with adults, but I think it's a big challenge for us as pediatricians because the visit that the child comes, when they come to our clinic, it's not only giving the vaccine and leaving. So we look at the family, we look at how the child is interacting with the parents. We look at how is the child gaining milestones, appropriate milestones. Does the child have any disabilities that we should pick up? That might be a big challenge for us to pick up by telehealth. So, and we know very well that many families, they need to come and get the support from the healthcare team when they come to tell the mom you're doing a good job and so on. So this definitely has put a burden on the parents as well on the physicians because we're not seeing them as much as before. The other question that comes up is what do we do? What's happening with kids with special needs? So very important is that, and I'm going to give you an example, the autistic kids who need special intervention almost on a daily basis. If they're not meeting this intervention, we definitely are going to see a delay in the speech and their social development that I don't know how easy it's going to be made up once the lockdown is over. And I gave the example of autism, but you have the learning disabilities, you have the kids who need physical therapy or occupational therapy, which can be a very big challenge for you to do it by telehealth. So this is all good and said and done. What else is happening with the lockdown? So we know that children, for them to grow, they need a supportive environment. And usually this is provided by the families, very, very typical. But in order to enhance this, they need to have a good quality of education. And actually they need the support of the school, which we know for the past few months, if not for the past year, in Lebanon has been missing because the kids have not been able to go to school on a regular basis whatsoever. Furthermore, because the children depend they have a developmental dependence on relationships. So any stress that happens at home is going to reflect on the kids immediately. So let me give you one of the big concerns that UNICEF has right now. So in Europe and in the United States, many schools offer for low socioeconomic kids a healthy breakfast and a healthy lunch at school, knowing that the parents might not be able to provide 3 meals. So at least for 5 days per week, these kids are guaranteed 2 meals per day. With them being at home, this has become unavailable. And UNICEF has raised alarm bells about the increase in hunger that we're going to see and malnutrition among kids. All right. Kids all of a sudden are left alone because they're homeschooled. The parents have to go out, look for welfare, social welfare, look for jobs. This is something new. The substance abuse has definitely increased. Okay. And then if there was an abusive environment, usually what happens is that the kids used to go at school, they had the teacher support, their friends support, so they could run away for a few hours. This unfortunately cannot happen right now. And in Australia, actually, they reported that there was definitely an increase in child protection, and there were many more calls for family violence support care. And actually, just talking from personal experience at the UBMC as involved in the child protection program, the first month of lockdown, we saw a tremendous increase in number of phone calls about child abuse. Parents were they were yelling much more than before, and we got more calls than we got in maybe a year. The other thing that I think we are going to see the effect down the line is that I don't think any family has not been affected by COVID. So you have death that has occurred in families, you have seriously ill, and the impact on the children really remains to be seen. So because of this delay, this also lockdown and pandemic, what has happened, and it has emerged everywhere, is that there's a delay in presentation to hospital for children who require acute care. And this is not only in children. I have to say we're seeing it in adults, and a lot of studies came out from Italy. So parents delay coming into the hospital, so until the last minute, until they really have to. So sometimes that can increase the mortality and morbidity. And I'm going to give you a very simple example. A child, 7-year-old, has right lower quadrant pain. The pediatrician tells them, please go to the hospital. It could be appendicitis. The parents are, we'll wait, we're fine, we're okay. They delay 3 to 4 days. So instead of being a simple appendectomy, staying 24 to 48 hours in the hospital, this child has to stay for 1 week in the hospital receiving IV antibiotics because it has gone on to perforate. Same thing with adults. There's a delay in presentation for myocardial infarction. Sometimes they're coming in too late and they're leading to death, and with the stroke also. So this definitely has had a lot of repercussions on increase in non-COVID related mortalities. Furthermore, what happens when we admit children to hospital, whether it's COVID or not? This is a very, very stressful time for the parents as well as for the child. So now under the COVID rules, there's only one parent who's allowed to be there. Usually you have the teta, the jiddo, the grandparents, the whole extended family who will come and make visits to just help with the family during that hospitalization. So all of a sudden, the child is alone. The child is sometimes scared because the healthcare workers are taking extra precautions. They're coming in wearing all the gear. So this can be very, very stressful to that. But at the same time, you want the healthcare workers to be protected. So you cannot tell them not to do that. The challenge for us pediatricians is when you have to make a decision with the parents, because usually the clinical decision is made by the parents and by the pediatrician, and we call it as a partnership or therapeutic partnership. So all of a sudden, you have one parent in the room, you have to go to telehealth with the other parent. So sometimes there has been a delay in reaching that shared understanding and to be able to reach a certain decision. So definitely this has been a challenge for pediatricians, I think, and as well as parents. So moving on to another topic that is really has raised a lot of articles have come up about leaving kids out from research. Okay, so as you know, the research, we are being bombarded with articles going on, and I'm going to focus on the research about COVID. And I think it is of utmost importance to have COVID-19, or whenever you have a pandemic, to have research ongoing, because it will give you more insight into the prevention and management of this novel disease. So typically what happens in the pediatric population is if you're trying a drug, for example, you try it in the adults, and once you prove it's efficacious, you will go on to include kids, but usually it takes a much, much longer of time. And the reasoning behind this is why aren't kids included is that they really worry about unknown side effects. Are the kids going to be able to talk about side effects and so on, and not being able to include enough patients, pediatric patients, to cover the study. Is that the drugs that are being used or going on trial are drugs that are used in general in the pediatric population for other illnesses. So the kids are already on them, yet pediatrics are being excluded. And one of the typical examples is the dexamethasone trial. So dexamethasone, for those who are non-medical, is the simple Decadron, it's a steroid. And you can use it from birth until age, there's no limit on the age that you can use Decadron. And it was one of the drugs that has been shown that it's really available, very cheap, and can reduce 1/3 of the death. So when they did this study initially, they had excluded anybody below the age of 18. And then all of a sudden, without any explanation as to why this happened, they re-included younger children. Yet pregnant and breastfeeding women were eligible. So even there was no concern about the drug on the fetus, but they excluded children. So that raised a lot of questions in the pediatric ethics about whether this was really ethical to do or not. Moving on, right now, you know the whole hype about the vaccine, and then that several companies have vaccines trials going on. Most of them are for the age of 18 and above. Only Pfizer has tried for children who are 16, or I should say adolescents who are 16 and above. Right now, there's an trial going on for the ages 12 to 16 to see if they can go ahead and use it on them. So they're leaving behind a very vulnerable population. And for me, that violates the action rule of equitable access to an intervention. And interestingly enough, 2 days ago, a very interesting article came out in The Guardian saying that according to some scientists, the only way to eradicate the pandemic is to vaccinate children. So can you imagine what we're talking in terms of years long to be able to do the trials in children and just to say that it's a safe vaccine and then to go ahead and vaccinate the pediatric population. So this is something that also has brought up a lot of press in the past few months. So the whole idea, I think, if I want to leave you with any parting words, is that we as pediatricians, we have to ensure the justice for the pediatric population. So we're not saying they have to be enrolled in every study, but we have to be their voice heard to make sure that if they are going to get any benefit, we have to make sure that we're going to advocate for that and fight for that. So moving on to the last topic, and I think this is the topic that's very dear and near to my heart, is looking at what happened in Europe. So you had the Italian experience, the Spanish experience, even in the United States and in Great Britain. But I think we heard it more about Italy and in Spain, where they got overwhelmed with the number of adults who required critical care units, that they had to move on and use the pediatric intensive care beds. Now, people can ask that in an emergency, should pediatric health resources be used for the community? I don't think anybody would argue that this is definitely yes to that question, because children are part of the community. So this is the community coming together to help out. But what happens if a child needs a pediatric critical care bed? And what countries have done, it has varied quite a lot. And actually, it has varied from institution to institution within the same country. So some of them, what they did is that they took some of the nurses or some of the physicians who do pediatric and moved them to adults to help out. Other cities that have children's hospital have decided that the children will go to that hospital, to leave the mixed hospitals like our center that takes pediatric and adult only to care for adults, which is also not a bad thing. Some even suggested that the neonatal intensive care, which usually sees newborns and prematures, start taking older kids to allow for the pediatric ICUs to care for young adults. So I think each city had to see what worked best for them. But most of them, what happened in the US is that the pediatric critical intensive care units started taking care of young adults. So, okay, we're here to help. This is an emergency, but is it without any risks? I really don't think so, because you're asking all of a sudden people who are trained in a certain way to go out of the realm of their comfort zone and start helping with adults. So you definitely, if you want to do that, have to have very clear guidelines and protocols to adhere by, just to make sure. And then and you're asking nurses to take care of adults when they're not used to it. So this also needs a lot of emotional and moral support for that staff. And also, I think on the patient side, when you are remodeling or reorganizing, instead of having a 1-to-1 ratio, so one nurse for one patient in the ICU, all of a sudden you're telling the nurse to take care of 3 patients that are critically ill. Also, that can have some, hopefully not, but it can be very stressful for the nurse and for the parents all of a sudden who are used to a certain level of care. So how do intensivists or pediatric intensivists, how should we make the decision which child gets the bed and should the child not get a bed? And I think this has to really be based on the clinical need and how likely is the child to benefit from the pediatric ICU. So this is a decision that has to be taken in with the family and the child, and especially adolescent. Because remember, we talk about child, we assume they cannot think for themselves, but we have kids who are 8 and 9 and 10-year-old who have lived with chronic conditions, who know about the disease and about their bodies more than anybody else. So whenever we're making such a decision, I think the child's voice has to be heard, and it's our duty to make sure that it is heard. The other thing, it's not only the intensivist. So if a child has, for example, cystic fibrosis, we have to make sure that the primary physician who's taking care of the child is involved also in the discussion about this. So comorbidities, are they going to affect the outcome? Is he going to benefit less? What is the prognosis of that patient? And the other thing that every country has been looking at is the consumption of resources for the patient to recover. So if I have a child who I know is going to stay in for 48 hours, recover completely, I can get him off the vent and send him out, versus a child who might take 2 to 3 weeks. definitely the choice is going to be with the child who's going to consume less, so we can have a better turnaround and have the ventilators available in case they need to be used. And then definitely you have to look at the holistic effect on outcome in the short term and long term. So the one thing that I think is very, very important to remember is that any decision we make cannot be based on ethnicity, socioeconomic class, or disability. And I just want to make sure that everybody's on board that I think differentiating comorbidity from disability is very important. So disability is looking at the quality of life and dealing with the quality of life also. So quality of life as good. Has to play a very, very major role. So they came out and looked in the literature to see, are there any objective tools that can help the physicians decide which patients can go to the ICU, should go to the ICU, and which patients we tell them no ICU beds. Somebody looked at the severity of illness, and it was found that really it does not recommended. There really are not any validated tools for this purpose. I don't know, it's after the pandemic, some tools will come out from the experience that all the countries have. None were developed for children and adults. And sometimes there is a frailty tool in the elder population that looks at how frail the patient is. So sometimes some people have suggested using that in the pediatric population, but we know that a lot of pediatric patients have a borderline dependence on the adult, but their quality of life good. So if you apply this frailty score, it's going to deprioritize kids, and it becomes really, really very unfair. So what has come out really is that basically to make the decision, the clinician judgment is superior to any scoring tool that is currently available. As I said, down the line from our experience with COVID, I don't know if something else will emerge from that. So in the pediatric or in general for allocating resources, they have found that there's two ways or two groups. One having the younger people, including the adults with caring responsibilities, whether it's for elderly, healthcare workers get priority also, versus a vulnerable or disadvantaged group. And a lot of people have come out and said, well, children are not a vulnerable group. And why is that? Because often they are considered well cared for families. The families are their advocates and defend them all the time. Yet, for me, they are the most vulnerable population because they're physically, financially, and developmentally dependent on an adult, and they really have no political voice or vote. So this is why pediatrics or children have really become, they have emerged as a priority in terms of allocating resources more than before. All right, so unfortunately, we have a lot of kids who have life-limiting conditions. So their cycle of life is short, or they have chronic conditions that we know or inherited the disorders that we know they don't make it into adulthood. So ideally, in the ideal world, all of these should have an advanced care planning directive with their primary physician. And this should be done prior to hitting a pandemic like what we are doing right now. So the idea behind this is that it should be multidisciplinary, so definitely involving the parents, because what we hear a lot is that although the parents know they have a life-limiting condition, they say, oops, but he made it last time when he went into the ICU. The ICU was good for him. Knowing that frequent admissions to the ICU it sometimes is a bad sign at the end. So a multidisciplinary approach, having the primary physicians, the parents, the child, the adolescent, offering compassionate care. And I think the most important thing, because we're all going into this not knowing exactly what's going to come at the end. So I think developing communication guidelines to help navigate conversations, because all of a sudden you're telling the parents, we're not going to give your child an intensive care bed. But at the same time, they really need to know that this doesn't mean abandoning you as a family, that somebody is going to walk the walk with you and be with you till the end. And for me, palliative care, and I really feel very strongly about it, should be part of any time of the overall response to any pandemic. They cannot be called in at the end. They have to be called in from the very beginning, because really, they are the ones who are going to ensure a high quality of compassionate and end-of-life care. And then some literature have suggested having triage teams. And what they mean by triage teams to assist the physician, because remember, all of a sudden, as pediatricians, we're having to make very dramatic and life-altering decisions. So we're telling families that maybe it's better for your child not to be admitted this time to ICU, and allowing the natural course of the disease to take place, not prolonging the inevitable. So they are suggesting models of triage teams where they have clinicians and they have clinical ethicists available 24/7 to be able to assist the physicians, so that you also don't burn out the physicians with having to make this decision. So in conclusion, I think we need to really start getting health services reinstated as soon as safe, okay, without putting anybody at jeopardy. And prioritizing intensive care, it is very ethically reasonable to consider according children some priority, if not a lot of priority. PICU should work closely with primary providers, palliative care, and I really insist they have to be on board, and others to optimize timely goals of care discussion and parallel planning. Palliative care surge capacity should be part of the overall strategy to address intensive care resource limitation. And decision-making processes, I think, should be done before we get hit with the pandemic. They should be as transparent as can be, as publicized as can be, so that all the parents know that there's a protocol we're following and the decision is not being made by one physician choosing one child over the other. Thank you very much, and we can open the floor for discussion.
Thank you, Dr. Majdalani. It was very eye-opening and rich. I'm sure many participants have a lot of questions. So I would like to come forward or through direct intervention or through the chat. You're welcome to ask any question.
It was that clear that nobody had, it was a very hard topic for me to be able to discuss, because as I said, I think we're very lucky that in Lebanon we have not reached the point where we have to make these decisions. And I hope we don't reach the point where we have to deny children critical care because the adults are overwhelmed and we need to help out the adults. So it is definitely a challenge. As I said, I hope we have to face the situation.
Marianne?
Yes.
Yes, well, we have faced this in our emergency room now.
It is in the emergency
room beds has been, well, at least the number of emergency room beds have been decreased, but luckily the number of emergency room visits have decreased markedly. So and this is again what our Italian colleagues were telling me last winter. So we have not seen the usual outbreaks of pneumonia and bronchiolitis, etc., that we used to see this time of the year. So in a way, we were lucky, Annie. So our patient population, the morbidity of our patients had decreased markedly. So
yes, that is very true.
Yeah,
this is why I said, in a way, we were protected. So we saw what happened in Europe, and we did not reach it. But I think our colleagues, the adults, are living it much more than we are. Yani the number of beds have come down for pediatrics, but at the same time, like in Italy and every country, the number of emergency room visits has decreased significantly. So when we used to see around 30 to 40 pediatric patients in the ER, right now, at some point in time, they were seeing 5 or 6. So the number really has decreased significantly. Brigitte, you were saying, would you get a consult mental health? Absolutely, absolutely, especially if the talk has not been done with the parents before. Now, a lot of our physicians are very good about walking the walk with the parents and talking to them, especially when they have a life-limiting disease. but definitely the parents need to have psychological support, and for the children as well. Because we've had sometimes kids who actually end up making decisions about their disease that goes against what the parents want. So a lot of times parents want to prolong more. When the children say, enough, I know my body, this is what my body is telling me to stop, and we don't want to. So definitely it is a comprehensive approach, and mental health plays an essential part of it. Hi, Hazar. So for the vaccine hesitancy, I think this is our biggest challenge as pediatricians, because you know already very well that there's already, without the COVID vaccine, there's a lot of hesitancy with some parents about giving the basic vaccines that we know can eradicate the diseases. It is going to be a challenge, and I would ask, there are a lot of my pediatric colleagues who are attending. I would like also to hear their opinion about this. What worries me is that because parents know, or the media knows, and it's very well publicized, that kids are not getting affected as seriously by their illness. So if anybody is a little bit hesitant, they might say no for the vaccine. So this is where I think the campaign and giving the correct information and pushing for it. But I would like to hear, I see Salman, Rima, and if anybody would like to pitch in and give what they think about this. Dr. Murwi, do you think there's going to be a hesitancy on pediatrics getting the vaccine?
The particular COVID vaccine?
Yes.
I don't think so. I think by the time we will get there, we would have had a good experience with the vaccine in the adults. So I think we would have started to talk about.
Okay. Okay.
It depends where the pandemic would have reached by then.
That's true. That's true. And then it depends also if we start seeing more and more pediatric patients with the COVID variant that we are seeing. So I think we know the vaccine is not going to come in the coming couple of months for the pediatrics, if not much longer than this. So I think time is on our side a little bit to be able to convince parents that they should vaccinate.
Doctor, since we're on the subject of vaccines, do you think this will affect like the regular vaccinations that children take? I mean, since the vaccine has spurred a lot of skepticism from the public about how vaccines are developed and how research is done to come up with vaccines. Do you think this will affect people's acceptance of other vaccinations?
Do you mean, Diana, that they would start saying more yes for the vaccines, for the old vaccines? Can you just clarify?
No, I mean the other way around. No, doubting vaccines that have already been used before, or any new ones that will be developed. Not COVID related, I mean.
Not COVID related. Look, I think Dr. Wakim, who's our idea expert, is saying that in terms for the question before about COVID vaccine hesitancy, it will depend on the studies that will come out soon from Pfizer and other companies in terms of efficacy and safety of the vaccine. So I think for kids, as we said, time is on our side. Maria, I will answer your question in 1 minute. Look, I really believe that the hesitancy about vaccines in general is amplified 1,000 times by the social media, and they're projecting a very wrong image about the vaccines and the side effects of vaccine and everything. So I personally, as I said, once we have the science in our hands, I think as pediatricians, especially when we have the trust of our patients and we follow them since they're born, I think it should not be a problem. We should be able to, if we think that the vaccine is going to make a difference, it should not be a problem. Okay. Maria is asking, how do you deal with situation when child's decision regarding goals of care related to his or own body disease contradicts his parents? Do you take the child's decision into consideration or parent? Actually, Maria, this is very, very challenging. And sometimes I think our colleagues in the CCCL see it a lot, especially when you have a teenager who's been through multiple trials of chemotherapy and is failing. And they come and tell them that we don't want anymore. We want to just, sorry for the word, die in peace. So I think it is definitely a challenge. You just have to make sure that the child is not depressed when he's making such a decision. I think this is very, very important. But from my experience and so on, what we do is we sit with the family together and just have the discussion. And a lot of times, actually, the children will be able to convince their parents. It's not easy to say for a child, allow him to die, but sometimes, I mean, doing too much to a child can have a negative effect. So we have to know where the balance is in those terms. And you have to go back to the quality of life the child is going to have. Is just pumping more chemotherapy going to improve the quality of life? It goes back, is the sanctity of life more important, and so on. So, but most of the time, the child's voice has to be heard. Absolutely, you cannot ignore it at all.
I'm sorry, may I come here?
Yes,
Sure.
please.
Yes, I'm sorry, I'm Jamila Rabi, and I am the Regional Advisor for Child and Adolescent Health in WHO. Dr. Hannah extends the invitation. Thank you, Dr. Marlene. It was really a very wonderful presentation, and I second every word you said. And I just want to share that the access of children to services, even to life-saving services, in each country has been affected. And as our colleague said, their coming to emergency has been affected, and the number is decreased. Even to their routine services like the immunization, the development measures has been decreased. And I agree with you that they are vulnerable because they can't take the decision. And even in the digital health or telemedicine, you can talk to the NCDs, children, adults, or to the women for family planning. But for children to meet their needs is not easy. So this has been affected greatly in low, high, middle income countries because of the restriction to the COVID. The other area, always the area of children and psychosocial support and mental health support is affected and short of services. And for example, in the Eastern Mediterranean region, the access to a pediatric psychiatrist or psychosocial is really very low. And so they consider it and they treat it as an adult. And this is much needed, more specialized care for those children, especially during the loss of someone from the family, how they cope with the stress, how to cope with the lockdown without seeing their friends. And it's really very bad when we see all the children in the classes with masks and their teacher and mask, and we say they will develop normal. How they will develop normal without this communication and freely communication, setting away from other. And this should be taken in consideration. Regarding the violence, we have data also from the countries that the violence has been increased during the lockdown. And it's obvious. A lot of problems, economical and social, and inside the house, the kids are the more exposed to this violence. And also, we tried in WHO how to support country, and especially the low-income country, how to cope with improving and continuity of services. But it is very wonderful to see this group of experts to talk about the critical care and how to come to be prepared for that. But also children in the COVID are hardly affected, and we have many cases of Kawasaki disease. Yes, and it did affect them, and we have deaths. of children because of care is not there, and because of the severity of the disease. Also, we don't know the whole clinical presentation of COVID-19 in children from 0 to 19 or adolescent, because it's different. It's not the clinical one and what we read. And we tried, for example, currently in 5 countries of the whole world, doing more to know the clinical presentation of COVID, even retrospective, to guide us how we can deal with that. So, you know, the point, as you said, the research targeting young people or young children or adolescents because of the ethical review and ethical approval, but this can be facilitated, especially we have to see how we can provide the care. Otherwise, we will lose the momentum around this. And adolescent, as you said, 10 or till 19, now they know that they can know what they are complaining of, and they know their diseases and they can participate. So we have to focus also on their participation in this and how to encourage them as a pediatricians, how to encourage them to know more and to take the decision more, because just waiting for another hit and we don't know about it among children is a big lose for all of us and for all pediatrics. Thank you.
Thank you very much for your intervention. So I am really worried as a pediatrician and about the effect that we're going to see once the lockdown is over. So we talked about the problems that are arising, but we know violence has increased. We know that a lot of, I mean, the kids, they're supposed to start school at 3. Our kids who started the nursery this year, they don't know their friends. They met them by Zoom. How is it going to affect their developmental milestones and so on? This is yet to be seen. But yet, I remember 2 weeks ago when Dr. Brigitte was giving her talk, I think if we want to look at something positive that came out of the COVID, and I mentioned it, is that all of a sudden parents are reporting that they're actually there for the milestones of their kids. When before they were busy at work, they're out of work, the child would take their first steps, the mom and dad could not be available because they had to work. And now all of a sudden that because the parents are at home, this has definitely led to bonding. And I want to try to find something positive out of the COVID. And I cannot be a pediatrician, but mention that also breastfeeding has increased significantly because moms are at home. So they're doing an amazing job of this. In terms of research, I totally agree. So when we're talking about 8 or 9-year-old, we have to remember that we have to get their assent into any research, and they have to approve of it. They have to know that it might entail drawing blood, and sometimes if there's pain, what we're going to do to help with the pain and so on. So it's not only getting the consent of the parents, but we also have to get the assent of the children, and this has been a requirement, at least in our institution. So thank you very much, Jamila, for your comments.
Hi, Dr. Majda.
Hi. Hi, Nicole.
How are you? Doctor, I have a question regarding, there might be a decision by the Minister of Education to open school. And I don't know if I missed a small part of your presentation, but, with us deciding whether we send the kids or not, and now that they're used to the online, we feel that we need to keep them at home. But I really need your input on that. If they ever decide to, let the kids go back to school, what do you think we should do?
Look, I'm going to talk as a pediatrician, then I'm going to talk as a parent. So we had a meeting with the Ministry of Education on Wednesday, and effectively they are looking back probably towards the mid of March to open the classes that have exams this year first, as a first trial, and it's going to be hybrid. So it's not going to be full days of classrooms in the schools. Okay, knowing very well that the data we have, with everything going on, even the badness, I think the Ministry of Education did an amazing job because they created a platform and they were able to track all the positive kids in the schools and how the transmission happened. And interestingly enough, in all the cases that happened, in all the schools, there was only one class that was affected. So most of the transmission that occurred in schools occurred between adults, administrator, and teachers. Very little, except for that class, happened between kids. So this is one to put aside. But granted, this was before we had seen the new strains of COVID that we know affect children a little bit more. So they're talking about doing it in a staged way, knowing very well that we're heading towards several closures because of religious holidays. So we, as the Pediatric Society, really endorsed, to be very honest, going back, because I really think, and I cannot overstress, for children's mental well-being, they need to go back to some sort of routine and to need to go see their friends, as long as schools are taking all the precautions necessary. So wearing masks for kids all above 6, hand washing, social distancing, no contact sports, and so on. And I think it's important for the parents, for the family as a whole, for some sort of routine to come back. Because it will help mitigate, as we mentioned before, if there is a lot of violence or screaming at home, sometimes just by going to school, the kids can breathe and just release the stress a little bit. And as a parent, I think I have to look into the context where I live. And we know also from what's happening in the economic situation that a lot of households have let go of their help. So right now they're relying on the grandparents and the uncles who are, or the elderly people in the families to help. So I think, I cannot say it's a general rule. I would encourage, and I would like to hear everybody else's opinion, but at the same time, I think it has to be individualized to a family situation and what is going on. So if the elderlies have gotten the vaccine, maybe it's safer, but if you have elderlies with chronic medication, chronic problems and so on, and you have a teenager, whether staying online might be a better option. And then the Ministry of Education is going to push for schools to give the option to the parents. Whether schools are going to abide by it, I'm not so sure. So I hope that helps Nicole a little bit. It's not an easy answer.
Yeah. Thank you. Yes, I know. It really depends if our parents get the vaccine before they decide. Yeah.
Let's see what's going to come out of the decision of the committee tonight and see what's happening. Yeah.
Thank you so much. Thank you.
Thank you.
And just to add on that point, I think a lot it goes back to the schools and how stringent they are with the precautions that they're taking. Because even before when they opened for a while, I still heard of cases with students reporting to school when they were ill, although the schools had requested for any kids that are sick to stay at home, or parents not being transparent in informing the school of family members catching COVID and reporting that. So
yeah, unfortunately, this is true for any situation, and even in regular days, and even we saw it last year with the flu. So you would know that if kids had the flu and they sent them home to school. So sadly, this is very true. So let me just, there's a question. If bonding with parents is replacing somehow interaction with peer. That's very true, Diane. It is a challenge on how to get the physical activity of the younger ones, because all of a sudden when parents are used to restrict any PlayStation, any TV, or any iPads to half an hour to 1 hour, all of a sudden now even younger kids who are 3 and 4 are sitting up to 4 hours on the iPad. This is why I think it's very important. And I just heard, I just got a message that daycares are opening on Monday, so with 25% capacity. So I think this is going to help. But this is a challenge on what to be able to do for the kids to be able, because it's not only we're seeing lack of exercise, also we're seeing weight gains with kids because they're sitting at home, and the easiest thing to go is to go to the kitchen, open the fridge, and eat something. So we have noticed a little bit in our clinics that there is some increase there's some weight gain among not only the kids and the parents as well. So it's all a stressful situation. So everybody is having to release that energy in some way. But this is why I think we really have to push. Now, the activities, in terms of physical activity. So the contact sports were not allowed, but they were okay totally. I mean, this is the CDC guidelines that you could do exercises or kids can do gymnastics with kids staying one away from the other. So it's not all activities that are going to be banned, but certain activities that really have the kids together too close that they are delaying having them do that. Okay, I hope that answered your question.
Dr. Marianne.
Yes.
I have just a comment regarding schooling.
Yes. Yes, Dr. Shabara.
My daughter is living at Lahai. The whole country is locked. Only preschool and elementary school are going to school.
Yeah.
Even the teachers are without a mask while they are with the students in school at school.
I know. And look, I'm going to tell you, in Paris, in France, there is a lockdown, and there are some schools that even for the kids that are older, teenagers, they did not stop them from going to school. So I think for schooling, we have to model what is best for us. And I know what the Ministry of Education, I forgot to say that, Nicole, actually the CDC came out with a very nice model looking at the number of new cases and so on to decide, and they classified them by color, that you're safe to open, not safe to open. And the Ministry of Education actually contacted the CDC, and they're throwing the numbers in Lebanon. So the CDC is supposed to give them back an answer whether it's actually safe for us to open or not, based on the numbers we're seeing locally. So as you know very well, I don't think it's easy for us to extrapolate everything from what's happening outside. We have very special conditions that we're going through. So I think this is an objective model, and we should be getting the results by the end of this week or early next week to see whether a school opening is going to be safe. I'm just asking the question, will result from lockdowns, okay, might result in the future regarding conditions that might arise. Hi, Eva. I am not sure we know what is going to arise down the line. I think several factors play on, and I don't know if Dr. Brigitte Khouri is still with us, and I would like to see her input into this. So the question is that, do we have any predictions for what might result in the future regarding the conditions of the kids being in lockdowns, like the physical and mental? There aren't a lot of data about what has happened outside. I mean, the Australian came out, and I mentioned it, that there's definitely more violence. But in terms of whether other problems should arise, I think it's a wait and see game, to be very honest. Should I? Yeah.
No, I was just checking if there are any more questions.
Okay.
I think seems no.
Okay.
Be respectful of your time. Thank you very much.
All right.
We kept you in the office.
That's okay. I want that team back. So I'm okay with that. Don't worry.
And I think this was a very interesting and enriching discussion. There was a lot to cover, but we got a few great ideas, and I hope everyone enjoyed it. And we can, of course, we are always in contact with you for any future opportunities as well. So with that, I think we can thank everyone, and thank you again, and we can conclude our session. And I think Dr. Arawi is still
I think the meeting is taking its toll.
Yes.
Yeah,
so.
Absolutely. We wish her luck. It's not,
of course.
Okay. Thank you very much.
Thank you so much, Doctor.
Thank you, Doctor. Thank you so much.